Hi, I am Dr. Vidushi from SuVi Eye Hospital, Kota in India, and in this video we demonstrate the technique of performing a frontalis sling surgery for bilateral severe blepharoptosis using a non-absorbable suture material, specifically 4,0 ethibond in this case. Now this is the pre-operative photograph of the child who shows severe ptosis, and the child also had chin elevation as well as frontalis overaction. Silicone sling is the preferred material and is used very widely all over the world. However, the cost is still a factor in the developing countries, and therefore suture materials have been used widely in countries like India, and in our experience give quite satisfactory results, as you will see here. Now these are the skin incisions being marked before performing the surgery. Three lid incisions are marked about 3 millimeters above the lid margin. There is a trend now to make these incisions closer to the lid crease. However, as we go higher up above the lid margin, the effectiveness of the sling may decrease, and therefore in cases of severe blepharoptosis like this one, it is important to mark these incisions closer to the lid margin to ensure good effectiveness of the surgery. Once these lid incisions have been marked, we then mark 3 incisions above the eyebrow. The 2 medial and lateral incisions are just above or just wider apart compared to the equivalent medial and lateral incisions in the eyelid, and the final suprabrow incision is about 1 centimeters above the brow. Once all the incisions have been marked, we then pass stay sutures through the eyelid margin and use a lid spatula coated with ointment to guard the eyeball. The marked incisions are then made, and the incisions are deepened down in the eyelid to the level of the tarsal plate. As you can see here, this is the white shiny tarsus plate that can be seen through the incisions. Similarly, the suprabrow incisions are also deepened to allow a good burial of the knots subsequent to the surgery. In bilateral surgeries, it is the symmetry that is the most important factor, and both the eyelids are being done here simultaneously, with incisions being made first on one eye and then in the other eye. We then pass the 4,0 ethibond suture through the lid incisions, and this is at the level of the tarsus plate. The correct depth is crucial because placing it very deep or very superficial can result in entropion or ectropion. After passing through the lid incisions, this suture is then passed into the suprabrow incision below the orbicularis muscle, and the suture track should be visible while passing it so that we can ensure that it is not too deep or not too superficial. So this is as described in the Crawford double triangle technique. Once we have passed the 2 triangles from the lid incision to the suprabrow incision, we can tie the knot, and these initial knots just above the brow help in forming a good eyelid contour, while the final height of the eyelid is normally determined by the final knot placed in the middle incision above the brow. These are the knots being tied in the incisions just above the brow. It is important in these incisions to make a good pocket by dissecting deeper so that the knots are well buried and do not lead to complications later, like in the form of exposed knots or suture granulomas, etc. We check the lid contour by adjusting the tension on these 2 triangles so that the lid contour is good. The lid contour is extremely important in the cases of ptosis. At some times it may even be more important than the actual height of the eyelid achieved, as a good correction with a poor lid contour will give a very unpleasant or displeasing appearance to the eyelid. One end of each of these triangles is then passed further up to the middle suprabrow incision, and then the final knot is tied, and the Tension on this knot can be titrated, as the tension here determines the final height of the eyelid. And we do the two eyelids simultaneously so that we can titrate each and every knot and ensure that the results are as symmetrical as possible between the two eyes. The knots are then well buried and the incisions above the brow are closed with 6-0 vicryl. The incisions on the eyelid need not be closed as they will heal on their own. And as you can see here, this is the appearance of the child after the surgery. Note that the height of the eyelid is very good. Also, the lid crease is quite normal. The slight puffiness above the eyelid crease goes away with time, as this is an immediate post-operative video. And the scars that are seen just above the eyebrow also disappear over 1 or 2 months. And the child, as seen here, looks very happy, and so are his parents. So in summary, sling surgery for severe blepharoptosis is the only option when the levator action is very poor, and it gives a very cosmetically acceptable result in bilateral cases because of the symmetry achieved. While silicone slings are the most widely used material all over the world, suture materials in the form of non-absorbable suture like 4-0 ethibond used here continue to be a viable option which give very good results at a fraction of the cost. Thank you very much.